Good afternoon, everyone, and thank you so much for joining us on this very important webinar regarding COVID-19 boosters and vaccines for younger children. My name is Jessica Collins, and I am the Executive Director of the Public Health Institute of Western Mass, and I am so happy to be joined by my longtime colleague and friend, Dr. Chrystal Wittcopp, who has been at Baystate Medical Center for the last 19 years and is currently the medical director at Baystate General Pediatrics, 140 High Street. Dr. Wittcopp is a graduate of the University of Rochester School of Medicine and Dentistry, where she also did a combined internal medicine pediatrics residency. Thank you so much for joining us today. We could not have a better person to help us understand this phase of the COVID-19 pandemic and prevention strategies, most importantly, vaccinations. So thank you, Dr. Wittcopp, for being here. We are going to be recording this session and we'll share the recording and the answers to questions on our website. We received many questions and we'll do our best to get to as many as we can now. Dr. Wittcopp will be presenting first, and then we will question and answer opportunity throughout the next hour. So thank you again so much for joining us. Thank you to the PHI team behind the scenes making this happen. And Dr. Wittcopp, I will turn it over to you. Thank you.
Thank you so much, Jessica. Welcome, everyone. It's so exciting that we have such a big group today to hear and listen and explore some around this topic. I came to Baystate 19 years ago in the midst of an emerging pediatric obesity epidemic and have been fortunate to work with Jessica Collins initially on Live Well Springfield initiatives and then going forward with the Public Health Institute of Western Mass. So I appreciate the opportunity and hopefully we can all learn together today. So feel free to type in questions as we go along. We'll try to get to as many of them as we can and figure out what we can learn together. I can go ahead and advance the slide. Great. So I just want to start with saying I have no disclosures. I think that's really important in today's environment to say I have no relationship with any of the products we're going to be talking about today, using brand names because those are the names that we're familiar with the vaccines. So you'll hear those mentioned frequently, but I have no financial disclosures. Good. So being a pediatrician, I did train as an internist as well in adult medicine, and 10 or so years into my practice, switched to all pediatrics because I always love a child's perspective. And I think they also help us to remain humble. And so I often try to view what the world looks like to them right now in the era of COVID-19, especially kids, who are 1.5 and 2 years old, and this is all they've known so far. It's really interesting to think about how are their perspectives being changed given the current environment that they're in, or not changed. And so, thinking what does COVID-19 mean to them, but also remembering how much we have to learn about COVID-19 and science in general. And so I preface this talk with, as medical and science professionals and scientists and educators, we are always learning and evolving, no matter what the disease state is, and we'll continue to do that with COVID-19. So where our knowledge 10 years from now is going to be different than our knowledge now. And so I prefaced my statements around that of what we know, and there's a lot we don't know that we still need to discover. Advance. So I wanted to start just a couple minutes with how do vaccines work. I think it's important that everybody sort of has a general understanding of vaccine technology and what we know about vaccines, which is a ton. And our vaccines all work in a very similar way, independent of how they're being delivered. So every virus, or if we have a vaccine against a bacteria, has a signature feature. And those signature features, which I'll here referred to, right, as the spike proteins that people have been talking about a lot, also what can be referred to by some people as antigens, sit on the surface of a molecule, and it's just a protein molecule. And those spike proteins trigger your immune system. They're what trigger us to have a reaction, or whatever that kind of reaction is in our bodies that the virus is producing. Vaccines train, so they're training our immune system to create other proteins that fight a specific disease. And these proteins are what people refer to as the antibodies. So the vaccine is trying to teach your body to fight off these things. And it's just developing other proteins. Proteins are just simple molecules, right? That we all have, that we've all always had. Once our antibodies get established, the response is much faster and more effective than the first time around. So when we start talking about boosters, once we have antibodies, the next time we see a protein that our body recognizes, we already have the proteins that fight that. And so we can develop a faster response. Pumps out those antibodies against that specific antigen or against that specific spike protein. Again, those words are kind of used interchangeably, meaning about the same thing. Some vaccines contain weakened or inactive parts of a particular organism. So we have vaccines available today that either have an actual virus particle in them that's weakened, or it's just taking a part of that particle and it gets delivered into our body and it triggers an immune response. The newer vaccines, like the mRNA vaccines, they contain a blueprint. So they contain the instructions for our body to produce these antigens rather than actually having the antigen itself be introduced. So I like this cartoon. It's taken from a place called Graphic WS. So this is the COVID molecule, and this is specifically talking about the mRNA vaccine. So they're the Moderna and the Pfizer vaccine. And so we have the coronavirus, you have the little spike protein on it. And when you look at the molecules underneath the microscope, right, they actually look this way. Vaccine technology is fascinating. All of science is fascinating. And so they take what's called an RNA, the messenger RNA vaccine, has coded for a template, and it's introducing that code into our bodies. And then our bodies are responding to that code, and they're creating the antigen or the spike protein. So it's not delivering the spike protein, it's actually delivering a code, a message to our body that says, create this, and then we produce antigens to what we've just created. And those antigens then fight next time that we're reintroduced to those same proteins. So, so that's the delivery technology for the mRNA. And then that messenger RNA, that part that's been introduced, quickly gets broken down in our body. So when they measure that, it's gone within a couple of days, possibly less than that, as well as the delivery vehicles that got introduced. And I only say that because a lot of conversation has come up about, can that messenger RNA then kind of weave its way into our genome and somehow alter it, cause infertility? No, because it actually dissipates, it goes away. Our body breaks it down. It never encodes into a genome. So it's just coding for that particular particle so that our body can respond to that in advance. So that's Moderna and Pfizer. Johnson & Johnson, which is the other most common vaccine available in the United States, uses a different type of mechanism. It's a more traditional type of vaccine, and it uses what's called a vector. So it takes adenovirus, which is a common cold virus, and it then delivers a piece of the COVID-19 virus DNA into our cells. So it's actually using a different virus to deliver a piece of genetic material from coronavirus into our system. And then we're forming the antigens against that genetic material. So it's different in that it's actually taking a piece of actual genetic material from a laboratory-made COVID-19 particle and delivering it into our system, as opposed to just taking a messenger to make that particle. So go ahead, you can go ahead. Yep. So the most important thing to know, right, is that the COVID-19 vaccines work before we get on to other stuff. So we have really good data that's telling us that COVID-19 vaccines prevent disease, prevent serious disease, prevent hospitalization and death. So this is data from Los Angeles County. And I like this graph just because it's simple to see. Other graphs you can pull out look the same as this. So this is LA County from May 1st to July 25th. So it's at the beginning of the Delta area, actually solidly in the Delta era in LA County. And what you'll see is that that black line, the black dash line, are the unvaccinated The smaller line is the partially vaccinated, and then the dark blue line is fully vaccinated. And this is number of cases per 100,000 people in LA County. So you'll see the huge discrepancy, right, between the dark black dashed line, the unvaccinated population, and the fully vaccinated and the partially vaccinated. So that's where this data is where people started to say, well, the vaccine's protecting us, probably 6 times protection if you're got vaccinated versus unvaccinated for getting infection at all. I'm going to advance. And then this is hospitalization rates. So again, the same lines indicating people who are unvaccinated versus vaccinated. And this is number of hospitalizations per 100,000, again, in LA County. And it's showing that, again, sort of this 10 times, maybe up to 30 times protection against hospitalization if you're vaccinated. And this is independent of vaccine type. So the people in this study either had gotten Moderna or Pfizer or J&J. So it's a mixed study. So again, really good evidence that the vaccine works to protect. We know that we've had a little bit of decrease in that protection as Delta variant has evolved, and probably more so as people have started to be longer away from their vaccination doses. So we've seen decline both in blood antibody levels, as well as some decline in protection against, in particular, disease, not so much against death, but also a little bit of decline in protection against hospitalizations. So why do we need a booster, right? So again, the first thing to know, which most of us know, is that almost all of our vaccines that we get, in fact, all of them that I can think about, have booster doses built in. So that's been part of vaccine technology forever. And it's not surprising to most people in the scientific world that we need a booster of the COVID vaccine because we've always had to boost vaccines. What happens is we create that initial response, right? So we have this primary response of antibodies that get built up in our bodies. And then that wanes a little bit. And then when we boost it, right, our memory kicks in. So we suddenly start to get this increased memory of antibodies. And the hope is that when you give a booster dose, or maybe 2 booster doses, that eventually you start to have long-term memory. So that happens with other vaccines. We've seen that happen with our series of childhood vaccines like measles, mumps, and rubella. Most of us still have those antibodies when we check them. Most of us still have hepatitis B antibodies. So if you work in the medical field, right, you get your hepatitis B antibody checked to see, are you still immune? Are you still protected? Hepatitis B is a 3-dose series. We give it in 3 doses because we know we had to boost it. So that is very similar to our COVID vaccine. We know we're going to have to boost that. But the hope is that eventually we get to a state where we have enough memory around where we don't need to boost it anymore. We don't know that yet. We won't know that yet, or we won't know if we need another booster dose yet. But if we follow other vaccines and vaccine technology, we should not continue to need boosters throughout life. The hope would be eventually we get to enough memory response that we're staying stable. So booster shots are administered to remind the body's immune system about the virus it needs to defend against, right? So it's just reminding us, it's just saying, hey, wake back up again. This improves or gives the immune system a boost. Booster doses are meant to remind, and so a response can be hardwired eventually. Go ahead. So Pfizer data for booster. So I'm going to go over some of the clinical trials that have the data in them to talk about for the booster doses. So the Pfizer data is the most robust of the Moderna, J&J, Pfizer data. So they did the most studying on that booster dose. So they had about 10,000 participants who were enrolled. All of those participants had completed the primary 2-dose series. They got randomized 1-to-1, so 5,000 of them were getting the actual dose and 5,000 of them were getting a placebo dose. The trial that was the phase 3 trial was using the same dosage as it used as its first 2 doses for Pfizer. So 30 micrograms is what you get when you get Pfizer, and that's what they used in their booster dose trials. They also gave 30 micrograms of a placebo shot if you were in the placebo. They then The median time between that second dose and administration of the booster was about 11 months. So a little ways out. When you think about when Pfizer conducted their initial studies, they were almost 2 years ago now. Well, they completed them. Started them. So their booster dose didn't come at 6 months. It was coming closer to 11 months for most of the people in the trial. Something to kind of think about. Symptomatic COVID-19 occurrence was measured at least 7 days after the booster or the placebo. So at day 7, they started tracking symptoms of people. They did this trial the same way they did their initial trial. They did not go through and swab everybody weekly to see if they had COVID. They were looking for symptoms, and if you had any symptom, which could be COVID, which is pretty much any symptom in the world, as you all know, then you got a swab. And we're seeing whether or not you had the COVID-19 infection. So at 7 days out, they started to measure people. Anyone who had symptom got swabbed, and then they followed that up. The median follow-up time for this trial was about 2.5 months. So people got followed for an average of 2.5 months, and then they closed the trial down because they thought they had enough data to go ahead and submit to the FDA. So in their trial doses, they had 5 cases of COVID-19 in the booster dose, in the booster group, so the group that got actual vaccine, versus 109 cases in the non-boosted group. So this, they reported out as a relative vaccine efficacy, which is kind of a confusing term at times, was 96%. So 96% of time, it was preventing people who got the COVID booster were prevented from having illness 96% of the time versus people who got the placebo dose. Now, these numbers seem low, like out of 5,000 people, right? This is all the people who actually got COVID, but remember, these are people who already have been immunized, so they already had baseline protection on board, right? So not a lot of cases in either group, but certainly less in the group that got the booster dose. The other way to think about that data is I like to turn it into something called the number needed to treat, for those of you who have done statistics. So for every 50 people you give that booster dose to, and people who have already been immunized, you'll prevent 1 COVID infection from occurring. There were no hospitalizations or deaths in the COVID-19 booster group. There were some hospitalizations in the non-boosted group. They didn't see any increased safety concerns. There were no different reported side effects than what had been reported out in the initial trial data. So there was no increase in safety concerns that they saw in what was 10,000 people. So much less than their initial trial, but nothing that was popping up as a red flag. Go ahead. The Moderna and J&J trials were not as robust. So Moderna kind of jumped on the Pfizer bandwagon, I would say. When we look at Moderna and Pfizer, their safety data seems pretty similar. Their efficacy data seems similar. Maybe Moderna was a little bit more efficacious in their primary trials. They're both mRNA vaccines. They both use a similar delivery mechanism. We wouldn't expect necessarily there'd be a big difference between their data, and the FDA kind of went with that, to be honest with you. So the Moderna trial that got submitted that led to the emergency use authorization had 149 participants in it. So they did not do sort of this big secondary trial like Pfizer did. Those 149 participants received 50 micrograms of Moderna which was only a half dose. So if you got Moderna vaccine, you got 100 micrograms in your initial dose and your second dose. For the third dose or the booster dose, Moderna submitted data that looked at 50 micrograms, and they then measured antibody response. So they did not measure clinical disease. They looked at antibody response, and they noticed that it was 10 to 20-fold higher in those who got that dose, and that was sustained over 2 months. J&J had a lot more data. So they had 30,000 participants that participated in a 2-dose trial. And in that trial, they had 1/2 that got the same dose as initial and showed increased efficacy of the 2-dose schedule against moderate to severe critical COVID-19. So they said that you had, so for moderate disease, that you had a 75% improvement if you got that 2 dose. But for severe and critical disease, you had 100%. So they didn't see any severe and critical disease in the people who got that 2 dose trial. So they had a good number of people and had good data that said, hey, getting that 2nd dose in the J&J seems to really work well and really increase efficacy. They, again, did not see any increased side effects or safety events in either Moderna or the J&J secondary trials. There were no increased safety concerns. They weren't seeing any side effects that they hadn't seen in the initial trials of the 1st or 2nd doses. So there's a third option out there when we're talking about boosters that you've probably all heard about, and that's this mix and match approach. So one of the things that came out recently from the emergency use authorization is that you could mix and match vaccines. So this actually also had a study behind it, and this study was not sponsored by any of the drug companies. So the other studies are drug company sponsored trials. This was a study conducted by the National Institutes of Health. And they had 458 volunteers. They divided those into 9 groups. So each group had about 50 people in them. And then they gave people who got 2 doses of Moderna, they gave them a 3rd dose of Moderna, some of them. Some got the 3rd dose of Pfizer, some got a 3rd dose of J&J. Same for the Pfizer people. Some got a 3rd dose of Moderna, some got a 3rd dose of J&J, some got a 3rd dose of Moderna. The J&J people either got a 2nd dose of J&J, a 2nd dose of Moderna, or a 2nd dose of Pfizer. So they did all those combinations, and then they looked at antibody levels. So again, they were measuring antibody levels. They were not actually measuring clinical disease. And they saw the biggest boost occur in people who had gotten the J&J, followed then by a Moderna or Pfizer. However, they saw very large boost in all groups, and sort of said, yeah, all of these combinations seem to work. Maybe some work a little bit better than others in terms of antibody levels, but we don't really know whether or not that's going to correlate with clinical disease. We know that when antibody levels increase, our clinical disease will decrease, but we don't know in terms of if you had Moderna and you get Pfizer, will that protect you as much as Moderna plus Moderna? We only know the antibodies look better. And again, there were no increased safety or side effects when they were mixing doses. So when you think about it from what I started with, which is how vaccines work, right? The mix and match approach from a scientific standpoint should work. And we've used it in other vaccines. We do mix and match vaccines oftentimes actually between different name brands to combat the same disease. Because again, you have this antibody response. You're just trying to boost it. You're trying to reintroduce something that makes those antibodies kick back in. And it doesn't really matter how you introduce that, right? How you introduce that spike protein. You're introducing it again in some manner. You have those antibodies there already. You're trying to get that memory response up. So the mix and match approach from a scientific standpoint should work well. It shouldn't have any problems with it. Go ahead. So based on all that data, they came out with their latest booster dose recommendations, which granted are confusing at best, and take a little bit of thinking about. So what has come out is, first of all, booster doses are only right now under emergency use authorization for 18 and over. So they do not apply to the childhood age group at all right now. And the guidance says that for Moderna and Pfizer, that you can have a booster shot 6 months after that after you've finished your series. So 6 months seems to be the time they want people to wait. And that for people who are age 65 and older, people who have underlying chronic health conditions and health histories, certain living situations that put you at increased risk of COVID infection, and employment situations that put you at increased risk of COVID-19 infection. For Johnson & Johnson, the recommendation is those 18 years or older who received the 1-dose vaccine should get boosted 2 months later. And that's across groups, so that they didn't put clarification on in terms of who should get that. So again, that's just 2 months afterwards that they said, you should consider getting a second dose 2 months later. And then the mix and match approach. So in the mix and match approach, you can, again, no matter sort of what your primary series was, you can choose to get boosted with the other one if you fall into those categories. So that was the recommendations they came out with just a couple weeks ago, which has led to, from what I'm understanding, a large uptake in booster doses, sort of in particular across places that are highly vaccinated. So people who are already vaccinated are much more likely to be coming in and getting their booster dose right now than people who are completely unvaccinated deciding to get primary vaccination, is what we're hearing. Go ahead. So this is data from Israel. And again, sort of so someone just put in the chat box, I saw it pop up, yes, so if you talk about antibody response, you can only talk about efficacy in terms of boosting antibody response. You can't talk about clinical efficacy. So just have to term what efficacy you're talking about. So this is real world data though, which I think always we need to follow up with, right? We always need to be tracking this and saying, okay, great. Clinical trials are either saying, yeah, in a clinical trial setting, we're decreasing disease potential, or, we're just increasing antibodies. We don't know how that correlates to clinical disease. We have a good idea how it should correlate. We just don't know what exact antibody levels you need to necessarily say this correlates to definite, protection here. And when you drop below a certain antibody level, you start to lose protection. We don't quite have that clarity yet. But this is trials out of Israel. Israel tends to be a little bit ahead of us all the time in terms of their data as well as their disease. And so this is looking at people and when they got their third dose of vaccination or their booster doses. This is broken down by age group. So they started vaccinating their above 60 year olds first. And you'll see that line is about the end of July there. And then their purple line is their sort of their daily incidence of disease. And so what you'll see is that they were kind of on this uptick already. And about 2 weeks after they start to give those boosters, you see this large decline in disease across those. And it's pretty consistent. So kind of each group, about 2 weeks after they got, some 60-year-old age group was a little longer than that, but the other groups, just about 2 weeks after, you'll see that they started to dramatically decline in terms of their daily incidence of disease. So, that makes you want to say, yeah, getting that third booster shot really seemed to impact those levels because of the timing of when you see the decrease of the curves. Go ahead. All right, so we'll come back to questions on boosters, but I want to switch over to the childhood COVID-19 vaccine, and I put here, and so the rationale between that and really the rationale for all childhood vaccination. So I don't think that the rationale for vaccinating for COVID-19 in children is different than the rationale that we have always used for why we decide to vaccinate children. So one of the criteria that we think about is that children act as a reservoir for disease. We know that COVID was a little different initially. Children didn't seem to act as a reservoir, but now they certainly are. So they tend to carry disease across communities. They tend to cohort with a lot of different people. And so they easily spread disease. The impact that COVID has had on education, child care, ability of caregivers to return to work has been, substantial, as all of you know, knowing the different organizations that you're coming from. So that is undeniable that it's more than just the impact on the children themselves in terms of getting sick, but it's impact across the whole system. So similar to when we decided to vaccinate against chickenpox, chickenpox had such a huge impact on all sorts of levels of society because parents would have to stay home with their kids for 7 to 14 days until the lesions crusted over. Child cares would have these sweeping outbreaks, same sort of thing. Impact of social isolation on mental health. So again, this is a huge concern, which all of you know, because I see many of you are in the mental health field, that we've had increase in anxiety, increase in depression, increase in suicidality in children, which when you sort of start to explore that comes from both the fear, some fear going on, as well as social isolation, not normal communication patterns for our children and our adolescents. There is increasing COVID disease in children, and there's increasing serious COVID disease in children. I'll show you some of that data in a second. And then, like I said, increase in childhood morbidity and mortality from COVID. So this data comes from the American Academy of Pediatrics. You can look on their site and they display a lot of this data very nicely. So this looks at the number of cases, and then the dark blue line is the percent of children of childhood cases. So what you'll see is right early on in the pandemic, we had a large, overwhelming majority of cases were in adult populations and not in children. And in this last wave, what we've seen is that our children are making up about a quarter of our cases. In some communities across the United States, it's upwards of a third, almost half of the cases in a few selective areas and communities that have been made up of children in this last wave. This is probably due a lot because a lot of adults got vaccinated, right? And so when you think about, well, if we have 70% of our adults vaccinated and hardly any of our children vaccinated, then we're going to see a much greater percentage of disease in children. And then the raw numbers have increased as well. And we think that's in part due to the Delta variant being much more contagious. For whatever reason, children are just better reservoirs for that disease than they were in the Alpha or the Beta variant. So this is summary of childhood mortality. So, you know, again, early on, people were like, oh, children seem to fare pretty well. We've definitely seen an increase in the percent of total deaths in children that are from COVID-19. So this is a nice way, right, to be able to look at data and say, okay, no, this is a true uptick. So back in the early days, so this chart starts in July. You can scroll backwards and you can get all the way to the beginning. So back in the spring of 2020 and the summer of 2020, this percent of total childhood deaths that we attributed to COVID-19 was at about 0.015%. In July, that had upticked to 0.06%, and now it's almost up to 0.1%. So a tenfold increase in the percent of childhood deaths that we're attributing to COVID-19 from the beginning of the pandemic, the earliest part of the pandemic to now. So it's a large increase, and we're feeling that. We had 2 children recently who died in our children's PICU here at Baystate from COVID-19. And so we're definitely actually seeing that on the ground from a clinical standpoint. Proportion of eligible US children who've received at least 1 dose of the COVID-19 vaccine. So this is our 12 to 17-year-old group. So the emergency use authorization for that came out in the spring of last year. And we're actually seeing pretty good response to that in areas of the country who already have pretty high vaccination rates. So you'll see in Massachusetts, actually, our data is saying 81% of our 12 to 17-year-olds have gotten at least 1 dose of the COVID vaccine, which is great. Across the country, not, wide variation, similar to our adult vaccination rates. So I would say that the 12 to 17 vaccination rate pretty much mirrors the adult vaccination rate for many of these areas, especially the older adult vaccination rates, right? Where we're seeing us really lag is sort of in that 20 to 40-year-old age group that kind of nationwide tend to be lower. And then, like I said, state specific. So, but in Massachusetts, good job, 12 to 17-year-olds, about 81% of them have had at least 1 dose. So this looks at data from Vermont, and I just use this graph again. There's actually a CDC graph that looks similar, and I couldn't find it for some reason to bring it up on a slide. So this is Vermont data, but the overall CDC data looks the same. So this is disease in certain age groups, trending from August, when we really started to see the Delta variant uptick, at least in Vermont. And you'll see the age group differentiation here. So again, 15 to 18-year-olds, so Vermont being somewhere which has done pretty well with vaccines as well, 10 to 14, and then 0 to 4 and 5 to 9. So the age groups that are ineligible for vaccination, right, have really been hit harder during this most recent wave, if we break it down by age. And so many of those 15 to 18-year-olds, so for Vermont, again, about 70% at the time this data was published, had been vaccinated. So again, you sort of see this discrepancy between vaccinated and unvaccinated population and percent of disease. So trials. So the trial of Pfizer in 5 to 11-year-olds. So this is what is, I think, sitting before the committee as we speak, I hope, to get emergency use authorization today or tomorrow, is the Pfizer data. So if you're interested, you can go to the FDA website and you can actually download the 80-page document of all the data that was submitted for any of these trials, which gives really nice data and information about what we know and what we don't know and how the trials were conducted. So the Pfizer trial for 5 to 11-year-olds was based off of 2,250 participants aged 5 to 11. And they did a 2-to-1. So they gave more kids the actual medication and less kids the placebo. That's because at least the time that they started the trial, COVID was not all that prevalent in children. And so they needed to increase the amount of children they were going to give it to in hopes to see a difference between the two groups. So about 1,500 got 10 micrograms. So 10 micrograms is 1/3 of the adult dose. And 750 got the placebo. That 1/3 was based off phase 1 and phase 2 trials, where they did a couple different dosing regimens, and they found that this one seemed to give really good antibody response, and that you didn't get more antibody response with a bigger dose. So that's the dose that they landed on, was that 10 microgram dose. They then followed them, they got the 2 doses 3 weeks apart. They followed them at least 2 months post-vaccine. And so they looked at both COVID infection as well as antibody and what they called neutralizing response. They said that the antibody and the neutralizing, so when they said, did it actually, like in laboratory environment, kill the COVID-19 vaccine, or at least neutralize it, then it was similar to the data in the 12 and over group and the adult group. So they said, okay, this is working very similarly in terms of what we're seeing on the antibody level. And then in vaccine efficacy, so in terms of preventing disease, it was 90% against any COVID infection for those that got the actual medication. They didn't have enough numbers to look at serious outcomes, because they just didn't have enough serious outcomes in either group to be able to compare that. They did not see any increased safety concerns. They didn't see anything, again, that was different than what they saw in the adult or the 12 to 18-year-old population. The FDA was concerned, and they will speak to that if you read through the document, that they didn't necessarily have enough included in the trial to be able to tease out some of those different areas that have come up as topics of concern. So the FDA has asked them to continue to enroll kids in trial, to at least do another 10 to 15,000 kids and follow those kids, so we can see any ongoing safety concerns. So the vaccine delivery here in Springfield, I think is going to be quite robust. I've been on several working groups that have talked about how we will deliver this vaccine to our children. Hopefully some will occur in schools. We have mobile units going out. We have pharmacies, CVS, Walgreens, the ones that are comfortable giving the flu shots to the younger kids will also be giving the COVID vaccines to the younger kids. Your physician's office, including here at High Street, we're going to have routine vaccine clinics once a week, and then stand-up, pop-up vaccine clinics that'll occur across the community. So I think there's going to be plenty of vaccine sites available to people, and kind of everybody is ready to go. as soon as that announcement comes out that we can do that. There will be a little bit of lag time. Again, it's a different dose, so it's coming in a different vial than the 12 and over. So you can't take stuff from the 12 and over vial and give it to the 5 to 11-year-olds. So again, there's a little bit of delivery stuff going on that hopefully will get sorted out. I do believe we've already gotten our shipments, but. So how does the FDA monitor safety? So just a couple specific questions, and then we'll move on to our question and answer period. So the VAERS system of data collection, which is the vaccine adverse event reporting system. This has been around forever. And from a data collection mechanism, it's helpful. It's helpful to be able to see if there are any trends that need further investigation. Beyond that, trying to draw any conclusions about causality from the VAERS it's just not warranted. You can report, anybody can report to VAERS. So you can call in any symptom that you are having. Hopefully people are actually having things at any time after you get a vaccine. So it can be 10 seconds after you get the vaccine, it can be 10 hours, it can be 10 days, it can be 10 months. And you self-report, so it's a self-reporting mechanism, or your physician's office or whoever administered the vaccine can report as well. It's done on kind of a trust system. And then the FDA is responsible for taking all of that data and looking at it and saying, okay, are there outliers occurring? Are we seeing trends that are worrisome? And do those trends make pathophysiological sense? So do the things that somebody is reporting in here, could they possibly have a causality? And if they do, then thinking about, okay, is it above and beyond what the baseline population actually has occurring for that disease? And then going from there. So that's the main way that we track different events going on. And the VAERS is reported to across the world. So different countries have their own type of recording, but other places in the world can also report to VAERS. So far across the world, about 7 billion doses of COVID vaccine have been delivered. So, there's been a lot of vaccine delivered out there in a very short time period. Go ahead. I wanted to speak just a moment for myocarditis. And then I said that I think this is my last slide, just because a couple questions came up around myocarditis. And because I think that is one of the things that is one, I won't think, looking at data and trends, there appears to be a slight increased risk of myocarditis in people who obtained the COVID-19 vaccine, Moderna or Pfizer in particular. So myocarditis is an inflammation in the heart muscle that causes pain, sometimes shortness of breath, decreased energy level. The Israeli data is, again, sort of the most complete that we have. They actually just published a study 2 days ago that came out in published form. So a lot of the information we get is sort of pre-published study data, which can, again, when you don't have all the data in front of you, you're sort of reading this excerpt, trying to understand it. So this actually came out in published form in peer-reviewed journal 2 days ago. And so it says that, first of all, this event is most likely, it's kind of 16 to 19-year-old men. They seem to be the group that's particularly at risk. It does occur in some other age groups. The true increased risk in those groups beyond baseline is a little bit less clear. It decreases in 12 to 15-year-olds, so actually be lower than age 16. We don't see it very often. See it a little bit sort of in 20-year-old men, so it's actually a little bit more prevalent. So again, 6 to 19 is the most common, and then kind of 20 to 30, and then early 30s. Beyond that, we don't really see it. In the younger age groups, not so much. A conservative estimate, if you look at the kind of baseline, what we've seen happen so far is that 20 cases per 1 million doses administered, mainly in adolescents. We don't know children yet. Again, we're sort of saying, well, if we saw the same thing in 5 to 11-year-olds as we saw in 16 to 19-year-olds, the risk would be 20 per 1 million that received 2 doses of the vaccine. 77% of the cases have been considered mild. They didn't require hospitalization. They had kind of no long-term side effects. They had some Motrin and got better on their own. There's been no confirmed pediatric deaths that I've seen reported, although I might have missed some. I will honestly say that because there's a lot of different myocarditis stuff out there. When you put that in context of, so 4,000 children aged 5 to 12 are being hospitalized for every 1 million COVID infections. Just to sort of put that in context, if we think, well, 77% of those cases are mild, so 2 per 1 million versus 4,000 per 1 million. And again, that's 5 to 12-year-olds. We don't really know what that's going to look like. And if people are a little confused about the myocarditis, they're still trying to figure out what it is about the vaccine that might trigger that response, how we might decrease that risk. But if we want to talk about sort of vaccine side effects that you want to say to people, yeah, this is something that we are seeing very rarely happen from this vaccine that seems to be increased above baseline incidence of disease, but not nearly as much of a risk as infection itself. All right, that was pretty good timing. Okay, so questions.
Yeah, thank you so much, Dr. Wittcopp. That was extremely comprehensive and thoughtfully done. And I love that you went back and kind of gave us an overview on the vaccine because it's been a while. I know folks have been doing a lot of outreach and education, but just reminding us of the science was very helpful. I want to start, we have more questions about children, but there was one question regarding the booster. So if we could go back to that from Amanda Mankowski, and she wants you to talk a little bit about the flu vaccine and the booster shot. Should there be a wait time? What do we know about asking people to get the flu shot and the booster right now?
So initially when the COVID vaccines came out, there was a recommendation to not get other vaccines along with that, because we really did want to monitor looking at side effects, what kind of side effects were we seeing. So the recommendation was no other vaccine within 2 weeks of your COVID-19 shot. That recommendation went away about 8 or 9 months ago. So since then, we've been routinely giving other vaccines with the COVID-19 vaccine. So the recommendation right now is that you absolutely can get your flu shot with the COVID-19 vaccine. You shouldn't have concerns about that. Again, 2 completely different types of vaccines. The flu vaccine is made differently. Still asking the same thing about antibody response, but we co-administer other vaccines. We've always co-administered flu vaccine with other vaccines. So people are not reporting that there should be a concern with that.
Okay, thank you. And then moving to the children vaccine question, a similar one, what's the answer about children also getting the flu? This is 5 to 11-year-olds. When it is approved, should that be a concern? Or not?
I don't think it should be a concern. I think that it should be fine. I think if you decide you want to separate them, that's also fine. So you just have to figure out which one you kind of want to get done first, but there should not be any underlying medical concern to getting both. Okay,
thank you. So your presentation did indeed answer many of the questions that had come in during the registration period, but there are a couple that we could still put to you. And one is when we think about health equity and different groups of people, different communities, are there any positive correlations with ethnicity or medical conditions and possible side effects for children with the COVID vaccine?
I don't think so. Since from the 5 to 11-year-old age group, based on 2,000 participants, I don't know that we can draw any conclusions around that. What we know in older kids and adults of the vaccine is that I have not seen any data that suggests that different ethnic groups have more or less side effects that are any different. I haven't seen any data to support that. I'll be interested to see if anyone has, but not from anything that I've seen come out. So different conditions. So there is some conversation around, in particular, autoimmune disorders, and not that the COVID-19 vaccine does anything harmful intrinsically, but in people with autoimmune disorders, sometimes they're already revved up, right? So they already have antibodies that are attacking their own body for various reasons. With any vaccine in those groups of people, if you're undergoing a flare of your autoimmune disorder and you give a vaccine that then revs up your system more to produce antibodies, that flare might get worse. So that's not unique to the COVID-19 vaccine. That has to do with lots of different vaccines. And it's just thinking about antibody response. There are some other groups of people where, if you're undergoing treatment for certain diseases that has you on certain medications, you want to have a conversation with your provider about when your timing of the COVID-19 vaccine should be. So I would say that same thing for children with autoimmune disorders, as well as, again, certain diseases where they're on certain medications, where making a vaccine may or may not be the right thing to do at that time, in part because the vaccine might not work. If you're on certain medications and you take a vaccine, the vaccine won't work because you won't be able to produce those antibodies.
Could you just give an example of an autoimmune disease?
Yeah, so like lupus, rheumatoid arthritis. Yeah.
Thank you. All right.
I would not put type 1 diabetes in that, although it is an autoimmune disease. It doesn't really flare that way. So again, we're talking about when your disease is flaring, you want to have a conversation if that's the best time to get a vaccine.
Okay. Thank you. Now let's talk for a moment about side effects, the vaccine for children and side effects. What should parents be looking out for? How long should you be looking for side effects in your child after a vaccine?
Yeah, great question. So the side effects in children appear to be remarkably similar to the side effects in adults. So site of soreness of the arm at the injection site is definitely true for the COVID-19 vaccine. Myalgias the next day, some low-grade fever, headache is one of the big symptoms that we see in people, usually occurring within the first 24 to 48 hours and resolving by the end of 48 hours. It is okay to dose with Tylenol and ibuprofen. If you need it and you're feeling symptomatic, you should do that. So the same thing as what we see in adults. Those are the big sort of what is termed as mild to moderate, mild symptoms in the clinical studies, which people who have gotten the vaccine, which you all know, right? Our own definition of mild symptoms might be different because for some people they're like, that was not mild. Like I was down and out for 24 hours, but it's short-lived. It's short-lived in the children. We haven't been seeing longer term side effects than that.
Okay. Thank you. This is a question I would love to have you take head on, which we have heard in the older youth population and some adults here of cause of sterilization. So this is coming up now for children. Can you please address that concern?
I honestly wish I could, Jessica. I have looked at the data on this. I've tried to figure out even where the conversation comes from. And from a pathophysiology standpoint, I can't wrap my head around even why would we think those two would be causally linked. There's no mechanism for that to be happening. Again, like I said, your genome does not get infected with the mRNA. It dissipates in your system after it gets injected. So there's nothing. Our studies haven't been going on long-term enough to even look at infertility even, right? I mean, we wouldn't know that if we wanted to, but again, there's no reason to suspect or think that this vaccine should cause infertility. We haven't seen other vaccines ever cause infertility. So my answer to that is I see no scientific evidence or data that supports that at all as a concern.
Okay, thank you. And also there's a good question before we let you go. Are they working on a vaccine for children younger than 5? Is that being developed?
Yes. So the clinical trials are ongoing. That took a little bit more dosing thought, and I don't really know I think they're even still thinking about, do our doses need to change less than 2? Do we need a different dose for 2 to 5 than we do for under 2? So those trials are ongoing. They have not been stopped nor submitted at this point for data. So that's where I know that's right now at.
Okay. And from a prevention standpoint, I think there's a good question around what else can we do to make sure our children's immune systems are strong, as well as getting vaccinated. What would you recommend to families for their children?
Yeah, so good solid nutrition. The the biggest risk factor for children for serious disease is obesity. So I'm going to put that out there. So thinking about how do we get good physical activity and exercise? How do we, again, keep mental health things in line for our children, helping them to stay mentally healthy is important. Basic hand washing, mask wearing, we know that works straight out of the box. So that's also helpful. All of those good basic nutrition, good rest, good sleep will help immune system. So.
Okay, well, I appreciate you repeating that. And then another question about how long for 5 to 11-year-olds would we expect these vaccines would last in protecting them?
So someone else asked about it is a 2-dose series. So it's similar to what adults got, where 1 dose and then another dose 3 weeks apart. And children are, in terms of antibody response, children are actually not always similar to adults, in particular older adults. One of the reasons we give vaccines in childhood, like hepatitis B and even HPV, which is the Gardasil, the one that protects against cervical cancer, is because children's ability to mount an immune response and have memory is better than ours as we get older. As we get older and our memories get worse, so does our immunological memory. So the hope would be that children will not need as many boosters as adults, that their antibody response, although its initial looks the same as adults, that it will stay higher longer, as it does with other vaccines. So if it works the same way as other vaccines, we should expect that our children may need less booster doses than we need, or booster doses spaced farther apart, because their immunological memory is just better, younger.
Yeah, everything's better younger.
Right.
So then it's to be determined whether this will be an annual requirement for schools or if the children will need a booster.
And part of that will be based on what the variants do. If we can get disease under control and stop variants, then hopefully we won't need to continue with ongoing boosters or different vaccines.
Okay. Well, we are just about at time, and I want to again thank you so much. And I want to thank you and all your team at 140 High Street and healthcare workers across the region